So, thank you and welcome to our January Lunch and Learn. I'll just do it without the slides. We will be keeping an eye on the chat. So if you have any questions during the time and you need, you can always put them in the chat. You can also unmute yourselves and ask questions out loud. That's totally fine. Afterwards, we will be sending out a survey about Lunch and Learn. And next month is February, and our speaker will be Dr. Paul Enlow from DuPont, speaking about mental health and cerebral palsy. So I'm now going to pass over to Laura Boyd.
Sure. Well, thank you everyone for joining us today. I'm so excited that it's our 4th Lunch and Learn this year, and HMS is very excited at how these are going and that we're able to access such wonderful speakers in this format. So thank you for joining us. We are excited to announce that Dr. Mary Stevens is joining us today. I had the good fortune of meeting Dr. Stevens, thank you, at a conference about 1.5 years ago. She was giving a presentation on transitional medical care and her practice model. And I was really impressed. And so I went up to her afterwards just to get brochures for HMS and say hello and thank her for such a nice presentation. And she kindly asked me where I worked, and I said HMS school. And then this beautiful look came over her face because she knew exactly who we were. And she actually was good friends with a family with a child who was attending HMS at that time. And the connection was made. So we stayed in touch, and then she kindly invited a couple of us to visit her practice last spring, probably late winter, right before everything shut down. And her practice was just so thoughtful. There was such a human touch to it, and it really addressed the needs of adults with special healthcare needs. And it was the humanity and thoughtfulness of it that I think struck Christine and I the most. Dr. Stevens was then due to speak to all of us at Parents' Evening last spring, which, as we all know, was unfortunately canceled. And we're just thrilled she can speak to us in this format and hope that it will be one day in person with all of us together. Dr. Stevens comes to us with 24 years of practice with board certification in family practice, which is the other interesting part, which I know she'll touch on, which is that she can see the whole family. Which for many families is just so welcome because it means that everyone will be able to follow up with their care. Dr. Stevens attended medical school and completed her residency at Jefferson Medical College of Thomas Jefferson University. She then completed a fellowship at the University of North Carolina. And without further ado, and because I don't want to take too much of her presentation away from her with all the parts that I was so impressed with in her practice, I will let her take it away. And thank you, Dr. Stevens, for your time and for joining us today.
Thank you. And Laura, are you going to run my slides for me?
Teresa's going to run them. I
Teresa,
have them.
okay.
Yeah.
So I'm excited to meet you all, and I'm excited that Lauren Gillespie has joined us today. So she was your speaker last month, and she, many years ago, was my social worker in the Down syndrome clinic at Christiana, and then I was the interim director of the Center for Special Healthcare Needs of interim director at Christiana, the Center for Healthcare Needs. She was there for me, and I think my first day on the job, we did a field trip in a hailstorm to a group home to try to clear somebody for a procedure under anesthesia because
your story.
Yeah. Because, you know, that's how we rock and roll. And now she's moved over to Nemours, and so I'm very excited to work with her still. And she's my friend. And we both agree, virtual education for high school students as parents is very challenging. So, all right, so without further ado, why don't we run the slides and we'll make this work. Can you guys hear me okay? Okay. All right, so we're going to talk about transition. So I reviewed Lauren's slides. I learned a lot from them. Unfortunately, we don't have a social worker yet, but I just got a text. We're hopefully getting closer. But I really rely on folks like Laura and Lauren and the team at the CHOP Transitions program that helps prepare our patients and our loved ones from this little leap of faith. So here we go. So next slide, please. So I have no official disclosures. I am funded through the National Curriculum Initiative in Developmental Medicine to bring a component of education about IDD to our med students at Jefferson. Sadly, it is still not a required part of the medical school curriculum, but we're working on it. And this is my daughter, Callie, who is officially double digits as of Monday. This is an older picture, but one of my favorites. So I hope you will embark on this lecture with the same joy and enthusiasm Callie embarks on life most days. She is 10, so some days are special. But really, I learned so much after Callie's arrival about challenges faced by folks with both intellectual and physical disabilities. I've now fired a few docs. I've kind of tossed things across my kitchen scheduling appointments. So, I mean, I don't know what your lives are like or your experiences, but I can tell you we've had some real challenges, and that's even just been in the pediatric world. And so with that in mind, that's some of the method behind the madness of what we try to do at JCCP. So at minimum, nobody throws things. All right, next slide. So I'm actually going to present sort of the medical model of transitions. Again, believe in understanding the method behind the madness and how national experts have developed a model that seems to improve outcomes in transitional care. So a lot of this comes out of Got Transition and Patients White and others. And then really interested in engaging in a conversation about your concerns and thoughts as we continue to grow our practice, which turns 2 next week. So we're still a baby practice, and clearly we still have growing pains, but we're trying. Next slide. So this is our focus. So looking at care in the adult world for individuals with disabilities or other complex chronic childhood onset conditions. So this is the focus of JCCP, and this is the focus of our initial slides. So in JCCP, we can start to see patients at the age of 14 and sometimes have found it beneficial, depending on an individual circumstance, to start transitioning that primary care piece of medical care earlier. So we have some time to get to know the individuals we care for, their families, and troubleshoot some of the specialty handoffs when they do occur. Next slide. So this is a statement that was in the journal Pediatrics, and I'll read it out loud in case some of you are just on audio. So this is really what we believe in JCCP. So optimal healthcare is achieved when each person at every age receives medically and developmentally appropriate care. The goal of a planned healthcare transition is to maximize lifelong functioning and well-being for all youth, including those who have special healthcare needs. So the transition from pediatric models of care to adults isn't really easy on anybody, but we know those patients who have multiple medical problems may have learning differences, can find it especially challenging. Next slide. So we believe in health equity, and not just equality. So giving people what they need. Those are my friends Preston and Deb, for any of you who know Preston's March for Energy. And my disclosure there is my daughter was fortunate to be gifted an adapted bike. So just to step back, so we started our practice in January of 2019. We're kind of a mini practice embedded in a larger primary care practice at Jefferson Health at the Navy Yard. We have rooms that are oversized. We also have some rooms, our rooms are a little more soundproof. So people can move around, bring their care teams with them. We have extended appointment times. We really try to minimize wait times in the waiting room. We have an option of patients, if needed, using our main waiting room, or we have a smaller secondary waiting room. We have now adapted to telehealth, which we picked up in the course of a week back in March of last year. Glorious 2020. Next slide. So this is what the experts say there are the 6 core elements of healthcare transition. So number 1, the pediatric practices you're at should have a system in place to begin the transition process. This can be in specialty care, but many think it really should be anchored in primary care, or whatever medical team is sort of leading the other medical teams. So, I mean, I know in a lot of minds, for folks of you who've been seeing at AI over the year, you know, Dr. Freeman Miller is not just your orthopedist or your child's orthopedist, but he's also your family doc. But whoever's leading the team should have a policy, should ideally have a statement about it. That transition piece should then be tracked and monitored. And assessment number 3 made for transition readiness and some orientation to adult practice. Now, for many years, this subpoint of number 3 has been the sticking point. So identify and list adult providers interested in providing care for young adults with complex needs. I will say, you know, we're making inroads in primary care, but we still struggle with this for specialty care in some departments. That's good. Next slide was good. So my colleague down at Christiana, Dr. Charmaine Wright, said, and I like this quote, the process should be a guided educational and therapeutic transition rather than an administrative event, as the cartoon depicts. But we do know some health systems do have defined cutoff times, although as Lauren can tell you, at Nemours, there are, I guess, administrative waivers that can be obtained to continue care past the 21st birthday. It's not just the hospital systems. There certainly are some hard stops drawn by insurers and changes in insurance benefits. Next slide. Number 4, really make sure all those records, including the medical summary, emergency care plan, and if needed, legal documents, and in many cases, power of attorney or guardianship or supported decision-making is important to have thought through and made progress towards achieving. Next slide. And yes, some of you will not be surprised if you actually printed out those records. They might fit in this box. We're lucky at Jeff to have access to care everywhere, but can't access it till the patient's first visit, which sometimes limits our prep time. But we're lucky when our patients are able to go through the transition services at Nemours or CHOP, because they come with this beautiful kind of snapshot of care. and high points we need to think about. While the flash drive is less cumbersome, we actually almost never can get them to work. So if we're going to have anything, we'd rather plow through some paper, bonus for us when the patients come with a transition summary. And many of our families have prepared those themselves who don't have access, and have their lists and their med lists, and it's great. But obviously we can't absorb, 14 to 21 years of somebody's life in a single visit. And we try to get the essence of major concerns. I've had a couple of people look at me funny when I said, so what are your goals of this first visit? And we really want to know what's most important to the individual patient we're seeing, to the caregivers, to decide where we kind of prioritize our efforts. Next slide. So ideally that transfer package is reviewed prior to the patient appointment. We've talked about logistically that's not always possible. And I will tell you now, having done this for a couple years here at Jeff and before at Christiana, sometimes the medical information is much more meaningful when we actually get to know the patient a little bit first, and their care team and their structure, and really have a context to understand things. And then really, initial goals are to address pressing concerns and prioritize healthcare decisions and needs. We consider transfer complete when everyone's connected with an ongoing care management program and connected with specialists and other support services. Now, most of the major children's hospitals in the area can provide some element of care after the age of 21. At Nemours, and Lauren can correct me if I'm wrong, it tends to be the congenital heart clinics and skeletal dysplasia. CHOP, initially when I started doing this 2 years ago, it didn't seem like a big deal for patients to continue their care past the age of 21, but now we're starting to see some hard stops, especially in the primary care arena. Next slide. This is what I feel like my job is, and our first couple visits are, and really figuring out, with the patient in the center, balancing the patient and caregiver roles, where patients are getting their current care, what works, where could they stay on, but they don't really want to. What can we offer in the home, especially now with COVID? Where do we have to connect things? So we have been fortunate. So the Navy Yard is a really kind of cool environment to practice in. We have free parking, which is almost unheard of in Philly. Our parking garage works pretty well for most people, less well since we started doing COVID testing in the garage, because it limits some of the first floor parking and doesn't work for the largest adaptive vans, but there's on-street parking that our families tell us works out pretty well. So I digress a little. So at the Navy Yard, we have GYN, although I'll do a lot of basic GYN for my patients and prescribe contraceptives for menstrual management, painful periods, people who are sexually active. In the building, kind of going from the top floor down. So our top floor is our oral surgeons and ENTs and audiology, who've been huge for our practice. Our oral surgeons have been really dedicated to our patient population, many because of underlying medical conditions or challenges with access to dental care over the years, need the services of an oral surgeon, but they've helped us coordinate complex sedations, helped us get folks into general dental care, and just been huge. For the patients we take care of, many have hearing loss and other ENT needs. My special interest, not surprisingly, is Down syndrome. And so certainly we see that a lot with that population. Next floor down, there's a surgery center, although we're not really involved there too much. But there's also some neurology, although not our epilepsy center, but some of our patients do fine with a general neurologist and we can refer them there. Also neurosurgery focused on spine, and Dr. Jim Harrop has been another big advocate for our patients and will also help me find the right neurosurgeon if needed for more of the brain issues, shunts, that sort of thing. Third floor, we have physical medicine and rehab, although unfortunately our spasticity services are still located down in Center City. General medical specialties, including cardiology and pulmonary, and on the second floor with us is urology. And we actually have 2 female urologists with which our young women often really like and appreciate. And urology has been a great partner for us. Many of our folks have neurogenic bladder. I think it was actually an HMS grad who had been admitted at Penn over the weekend, came to see me for a follow-up. His culture came back. There was no oral antibiotics we were able to give him. I think it was right before Thanksgiving, so there was really some pressure to get this right. And I walked over and I said to one of my partners, Perry, I need a favor. And he's like, of course. So I saw him late morning. The patient and his mom were able to hang out in the exam room. The medical student that was working with me hung out with the patient while mom ran down to the cafe to get something to eat. They went over to see Perry. He got a shot of IM gentamicin and established care with a urologist. So I mentioned med students. We do have med students and residents who work with us. I mean, I think we really need to think about the larger future workforce for the patients we take care of, and our students and residents have really embraced this complex care, as well as the advocacy and equity and disparities that are such an important part of what we do. So we don't have it all at the Navy Yard. It doesn't work for everybody, but it is helpful. Like I said, we're still a skeleton crew. We do have somebody, Erica, who helps with complex scheduling. So some folks do better with just one visit in a day, but some, if we can arrange for the renal ultrasound downstairs in the morning, see the urologist and see me, because there's such effort put into getting out of the house and getting all the pieces lined up, Erica can make that happen. Next slide. So that's what it is and why does it matter? And I think you all have your answers. Next slide. So you may have heard this term already. It's something I emphasize in lectures, that for our patients and their families, it can feel like a cliff. There's differences in insurance coverage, language, philosophies of care between the pediatric and adult world. And while we do really want to focus on patient autonomy and self-direction, we recognize that caregivers play an important role in ongoing care of our patients, and that nobody can really do this alone. So we try to make it feel less like this, but it can be tough. And again, I really do, I put this up not to scare you, because I think some of you are probably already starting to have nightmares about this, but I really put it up to other medical audience so they know what a big deal is and that they need to jump in and do their part. Next slide. So I've really kind of told you a lot about the philosophy of our practice, because I think it operationalized some of the things on our earlier slides. You know, we do know from the medical literature, caregivers of patients with disabilities, their health often suffers for folks who are caring for someone with physical disabilities, including cerebral palsy. They may have a lot of musculoskeletal concerns as their loved one grows and they're still providing care. So since I'm embedded in primary care and since I'm a family doc, we really wanted to be able to open our services to care for the whole family. Sometimes, we want to create a safe space for mom, dad, siblings who are involved in the care, but sometimes it's nice for someone to understand some of your background story, and kind of work with you to establish goals of care, and have an understanding of what your day-to-day life is like. And sometimes it's just good to have a quick visit, to have your blood pressure checked and your meds renewed while you're already there for something else. So there you go. Next slide. I've touched on most of these points. We do have that birthday coming up. I guess we can't have a cake this year, but maybe I can do cupcakes for our team. We do have a dedicated medical assistant, Janet, who is really phenomenal. We have access to 2 RNs now within our practice. Irene tends to do a lot with equipment needs. We've been able to connect with a nurse practitioner in the community who does home wound care visits, which has been critical for patients during COVID. Our other nurse, Kelly, has been really involved with triage, and came from hematology, so is phenomenal at blood draws. We really try to do a lot with our patients in the room. So recognizing going to LabCorp or Quest just may not be a viable option. So Janet draws blood on a lot of our patients. We do our own ear lavages when appropriate. And we do have backup for folks who are that tough stick. We do have some access to social work now through the system, and I do tap on my friends in the community like Lauren and Laura and others to figure out some complex situations. Have had some good tie-in with PCHC, but I think we just looked at it this morning. We've had 180 unique encounters in these first 2 years. It's getting a little bit big for me to kind of visualize every patient in my mind and kind of keep track of that. So the system is aware, they're very supportive, and we hope to see growth to our team soon. And again, we've really worked hard over the past couple of years of building our specialty network and can provide coordinated appointments. Probably the biggest challenge we have is finding orthopedic care, which I know is a particular interest to this group, for folks who only have Medicaid coverage. Folks who come to see us, the Medicaid that we take now is Keystone First, but that's not taken by Penn Orthopedics. There's challenges with Rothman. We're trying to continue to build bridges. I suspect Jefferson's, the number of Medicaid products they accept will be growing, but we do the best we can. A lot of what's done by orthopedics in the pediatric world is done by primary care and physical medicine and rehab. And fortunately, this program was the brainchild of Steve Williams, the chair of PM&R, and we have great access, including during a pandemic when your patient needs their baclofen pump filled, but can't make her first appointment because she has the flu in the first week of the pandemic. So who knows what it is. We were able to coordinate a telehealth visit with the rehab doctor so her baclofen could be ordered, and she was able to get into Dr. Hecker's office for her pump fill when she no longer had a fever and wasn't contagious. And we avoided certainly baclofen withdrawal, but also an ER visit, which nobody wanted to do early on in COVID, and nobody really wants to do on any day of any year. I've talked a lot. I think that's the last slide. Oh, some accommodations we have, again, 1 hour initial visits, 40 minutes follow-ups. We really want our patients who are able to communicate with us, whether it's verbally with a communication device, nonverbal language, to have that time. Also, there's a lot of history to learn. And for many of our patients, waiting doesn't work. Our rooms are oversized, and we've really not limited the number of folks who can come in with patients. I mean, we do ask folks to, really include the people that are necessary as we're trying to limit spread of COVID. But, if mom and dad both want to be there and the nurse has valuable information and she's part of your team, that's fine. We do use our semi-private waiting area if we can't room people directly. As we get to the part where our young adults want to spend some time alone with me as a provider and talk about the things that young adults want to talk about, and really to give them a chance to test their knowledge of their own history, their own meds, and not necessarily rely on other caregivers. We have a wheelchair scale, we have a Hoyer lift, and then we have a Leah chart for vision exam. So if you don't know letters or you don't speak, you can point to the shapes and we'll get your Special Olympics form filled at the time of your visit. And next slide, which I think we already covered. So next one. So there is an epilepsy center at Jefferson for folks with complicated seizure disorders. And we work with its director, Dr. Sperling, to direct our patients to the right provider. Next slide. We do have a website. It has a little video that I did. Here's my email if you want to reach out, and that's our phone number. I see a question in the chat, which I'll answer now so we can leave that last slide up, and then maybe we can take the slides down and have a dialogue. So from Lori, is there a health system where you can access our child's records from specialists like they do in all our doctors? Our child's doctors are with one hospital such as Nemours. So yeah, so through Care Everywhere, we can access all the Nemours records, but the way Jefferson's Epic is set up, which is our interface with Care Everywhere, you actually have to sign consent for that at the time of the first visit. So that's why we can't do the preview, but usually Lauren will fax a summary ahead of time so we can get a little bit of a spot check. And then we dig in a little deeper once the individual gets there. Interestingly, some of the outpatient billing requirements have changed, and we get credit, if you will, for reviewing records on the day of service, but not before. It is what it is, but sometimes, we still do a little study work, but it helps in terms of the financial structure of our practice if we can get credit for the work we do the day of, because this practice wouldn't exist if it wasn't supported by the health system. All right. So I'll leave it open for discussion, questions. Lauren, anything that I said differently from you or you feel like I should mention? Sometimes Lauren knows what I'm thinking before I'm thinking it.
No, I think you did a great job. I think that was really informative, and I learned some stuff too about what you're doing over there since I haven't been able to visit because of COVID.
No.
You did a great job. Thank you.
Thanks.
Dr. Stevens, there's a new question that came up in the chat saying, my daughter's on Zoloft and has been for years. If established history of medication is provided, is that something you would prescribe, or would we have to continue to see a psychiatrist? It's a great
No,
question.
for SSRIs, we're happy to continue to prescribe. Sadly, I've started way more Abilify than I ever would have wanted to this past year, because we really have some of our folks with complex behaviors and autism just totally struggling with this change in our routine and heads going through walls. And what I would love to engage with a psychiatrist. We really have issues even at Jefferson, although we're trying to make some changes accessing them. And we recognize a lot of people to get psychiatric care have to pay out of pocket. Family told me yesterday it's $300 for every visit, and they require visits for med refills, and it's within my scope of practice to do. As a family doc, some of the most common conditions we treat are anxiety and depression. We know that for folks with intellectual disabilities, the scales we use in the adult population don't necessarily translate. And sometimes we have to look at other markers for making the diagnosis and then the success of our therapeutic intervention. But Zoloft's an easy one. No need to see psychiatry for that. We do have a behavioral health consultant. While she's not dedicated to JCCP, she's part of the primary care practice. And she's done a great job with working with our patients. And they've really felt her service has been valuable. So we can add that therapeutic piece, at least for a short term, while we try to engage more mental health facilities. So there's a question in the chat about what hospital do you admit to? So our patients get admitted to the family medicine teaching service at Center City and the hospitalist service at Methodist. But some of our patients come from a distance away. So many end up admitted to the outlying hospital, and then through the transfer center can be transferred to Jefferson. For some of our patients who see a lot of specialists at Penn, they'll go to Penn and will, communicate with the team there. One of the things on my wish list, if we have a dedicated RN or case manager, and I think certainly a dedicated social worker could play part of in this role, is being a liaison with the inpatient team. The only preference we have for nursing are things like strategizing families who are having challenges with staff at the hospitals, really understanding the GJ tube or some of the urologic regimens. That might be helpful, but that's in the growth plans, but not quite there yet. Fortunately, through Care Everywhere, we do get alerts for folks who were admitted to mainline hospitals, DuPont, CHOP, Penn. I'm not sure about Crozier, maybe, but we try to keep on top of it. And then we communicate a lot with our families through MyChart, which you've used some version if you go to Nemours or CHOP. And so a lot of times our families will be the ones to let us know. And Jefferson's had, our families really have had success with during COVID, where they have allowed caregivers to stay with our patients without us having to argue about it. Bruce Meyer, who is one of our senior leaders, has many children, a few who are neurodiverse, and as the mom of a 15-year-old, I think all our kids are neurodiverse. Lauren is Meg Keegan, she can speak to that, but it's been, we haven't had to fight for it. I did have a family admitted to an outlying hospital who just picked her granddaughter up and took her out. When I talked to her yesterday at length, I was like, oh, next time, please call. One of our docs on call could have helped you, and here's my cell phone if this happens badly again. It's just a family where things really seem to happen to. So question from Dina, yeah, we can do telehealth to establish care. Obviously it limits our physical exam, but sometimes for the complex history taking, it actually works better. It gives me a chance to meet the individual patient. but I've, it's been fun for me with some of my established patients. Like I finally get to see Patty use her communication device and how she gets around her house with her wheelchair and that kind of thing. We've also used the advantage of people being more comfortable in their own home to their advantage. And that if you're going into details of this osteotomy and that thing and things that, yes, the individual may need to know, but really may not understand, but they might read that emotion like this was a terrifying episode of their life for you. You can have that conversation in another room with me, which we can't readily do in the office so much. Oh, the program at Methods with the hospitals, most outpatient docs don't do their own hospital care. So Methodist, like other hospitals, has a hospital of service. It's actually now staffed by one of the docs is a family doc who finished her training and rotated with me at the Navy Yard and has heard my lectures over the past couple of years. So she seems to be really interested in caring for our patients and sends me tiger texts and emails and updates. So it's been a nice in. Oh, how would a visit look if both a parent and their adult child are coming to your practice for care? I mean, in general, for the parents' care, I'd like to see us have our own room when we did that visit. So you can really say what's on your mind. If your child is able to stay in an exam room by themselves and be fine, we usually have enough space to accommodate that. If you needed to bring a caretaker along, you can do that. Yeah. I mean, if we have to, like, if it's a quick blood pressure check, like, is this new dose of amlodipine adequate for your blood pressure and you just want to be in and out, we can do it there. But at least for a first visit, I think it would really help get things on the table. Certainly anything related to psychosocial stressors, mental health, I think we really should try to create some separate space. Did that answer your question, Laura? Okay. Other thoughts or questions?
This is more of a logistical question. What insurances does Jefferson currently accept?
So lots. Erica helped screen that. Our only Medicaid product is Keystone First. So there's a weird glitch where Jefferson primary care is closed to all adult new Keystone First patients. Keystone First has acknowledged that our practice is different and that we're very open to taking them, new adult patients. So what we need our families still to do is to call Keystone First, be told, no, she's not taking new patients, politely get that person's name, hang up the phone, don't try to fight it. Call Erica and say, hey, I called, and then she faxes an override letter that Keystone First helped us develop and to Pat Squires, and it happens. Now it's taking about 7 to 10 days since the pandemic, but it can happen pretty quickly. With the merger with Einstein, I don't know if that'll open the door to health partners. And in general, Jeffersons have more of a focus on health equity. So I hope there are more opportunities for folks who have a Medicaid that we don't accept if they have another primary insurance, which many commercial insurers will cover adult individuals with disabilities until the age of 26. We've used that. Specialist care is usually covered. So that helps. So we try to make it work. We do take Medicare, which a lot of our folks kind of are triple covered, especially in their early 20s with commercial Medicare, Medicaid.
Can I ask a question, please?
Yeah.
Thanks. This is Dina, Madison's mom. I'm just curious to know, we had to have Madison's like well checkup because we were requesting a letter of medical necessity from the office and they wouldn't provide it because she hadn't been seen because of the pandemic.
Yeah.
So that was, I believe I would say about 2.5 months ago. Do I have to wait until next year to establish new patient
No,
with you? I don't.
No, not at all. We would just not use a preventive care code. We would use a problem focus code, which honestly, it's really hard to bill our first visits as wellness visits because technically with most insurances for a wellness visit, you're just supposed to be talking about well things and not managing any acute issues.
Okay.
So although sometimes we can swing it, and if folks are double covered with Medicaid, there's not much advantage to pushing to build the well visit unless, it meets some sort of requirement with the system. Our general patients without Medicaid like when we can bill a wellness visit because then there's no copay, which we recognize is totally important, but it's not a barrier to care.
Okay, that's great.
Yeah. And then for Lori, we've actually struggled with marketing because Jefferson isn't used to marketing to the IDD community. And so I started a practice with 0 patients. I got here August of 2019. We opened up January of 2019. Lauren actually sent me my first patient while she was still at Christiana, sort of before our start date, because she recognized that as an adult, he couldn't come to Christiana with his Medicaid. So we've sort of taken off with word of mouth. So yes, we can accommodate new patients as early as next week. We'd love you if we're doing things well. You let your friends know if there's things you think we need to work on, let us know, because then sometimes we know we need to work on it, but we can share that information with admin. So yeah. Oh, you're a marketer. We are eventually going to have a council of, patients and caregivers. Right now, I don't have the bandwidth to do it. I kind of am the lead physician. One of my partners, Michael Herchick, who's an Abington grad, who's phenomenal, has jumped in and backed me up. But I think admin is finally hearing what we're doing and gonna give us more support. But if we can get our number, like my goal was to get to 200 patients by our second birthday or 225. We're coming up a little short, but we got through a pandemic where in a week we started doing telehealth and we never had a month where we didn't have a new patient and our volume's starting to go up again. So yes, bring your loved ones, you come, tell other people, tell us how we can market.
Do you have any literature? Like I know right now you're talking to the HMS community. We used to live in Delaware and go to another all special needs school, Leach. And I'm wondering if you have patients from there or if they're aware. It's a little further drive, but it's the sort of thing that those families worry about as well. Is there any information I could pass on to those families?
If they live in Delaware still, they probably would want to go to Christiana Center for Special Healthcare Needs because adult Medicaid doesn't cross state line. For primary care. For specialty care, it does. And certainly I refer Jefferson families from Down Syndrome Clinic to sleep medicine here because they do hypoglossal nerve stimulators. So yeah, and I know some of the folks from Leach or Leach grads, and they've started this EPIC program, which is amazing. Jack and Terry.
Yes.
So it was actually Terry Hancherek who helped me get this job because when I left Christiana, I thought they might close Down Syndrome Clinic. And Terry's like, well, they're starting this new thing at the Navy Yard. You should cold call the chair of PM&R.
Oh, that's awesome.
And I was like,
go-getter.
Yeah, really? And she's like, really? And so she got me an intro and they're like, yeah, you can have a Down Syndrome clinic here, but why don't you come be our new primary care director? So
do you work, I'm sorry to hijack the conversation, but do you work with other Nemours locations? I mean, I'm sure you do through Lauren, but I'm on the Family Advisory Council
Yeah.
at Nemours, and I'm wondering what information, or Lauren, have you talked to all the other specialties?
So we, I'll jump on this, Roland. So we have a great relationship with Nemours. We work with Cindy Bowe. Bill McNett is a primary care provider right on Chestnut. He and his nurse Robin are like the dynamic duo, care for, through their special babies program, a lot of special care nursery grads, many who have cerebral palsy and other complex childhood onset conditions. And he and Robin and Janet and I have this cool thing. It was cooler before COVID, where they come down and they do direct handoffs with their patients. And we take family pictures. Now Robin will often come down and Bill will sort of beam in via FaceTime. And he and I teach a lot together, and they're both on my speed dial. And I think Lauren and Cindy Bowe have done some work with the PA Nemours practices beyond Bill.
Okay. Thank you.
Sure.
Sorry to hijack the conversation.
And you can send our website link out to all your friends and family and post it in your Facebook groups. I'm not allowed to do that, but if families want to take that initiative, please do. I know that's how I find a lot of my information, like where do I get my daughter's SMOs or now her orthotics without seeing an orthopedist. So
I will let you know that you are very highly recommended, that there have been messages on Facebook from other parents who have children with needs that have come to see you, and they are putting your name out there on Facebook. And also DuPont is recommending you, I think, to everyone, or many people, but your name is definitely getting out there, and you definitely come highly recommended.
well, we try. I feel like I've gained baby weight from starting this practice. There's always an excuse when you're over 50, right? I think we got all the questions in the chat.
Yeah, thank you so much, Dr. Stevens. This was wonderful. I will say we have some HMS grads who you do see, and we hear nothing but absolutely wonderful things. So thank you. And I appreciate that slide about the cliff. And yet I think it's programs like this that make the cliff a little bit less steep. And, you know, our families where medical needs stop and start and educational needs stop and start are pretty blurry boundaries. And so we really recognize at HMS that figuring out good medical transition and supporting that and trying to connect families with resources is critical to a happy and healthy transition and a happy and healthy family. And I think the name continuing care is also pretty impactful, because not that any place would ever be named, you know, stopping all care or changing all care, but I think it's the continuation. I mean, that's the hope from HMS when we look for adult programming, that it will be a continuance of all the good that's been happening. And it sounds like that's what's happening in your practice with all the medical care. So thank you very, very much for sharing this model with us.
Sure, glad we could. We talk a lot about momentum and trajectory, and you know, sometimes a reasonable goal during a pandemic is just maintaining your trajectory and not going in the wrong way. But in general, we really want to continue with the forward motion, because for many individuals we see, you know, that brain is developing and growing and learning well into the 20s. But if the individual is not getting the medical care they need, the other cognitive stimulation, we just got to keep going.
Absolutely. So thank you. And if there are other questions, please, we can connect you to Dr. Stevens in her office for more information.
Cool.
Okay.
All right. Have a great day.